Welcome back to Made to Be Whole. We are going to be talking the next few weeks about cancer prevention, screening, and treatment, and what integrative medicine can offer you in those fields. Stay tuned.
Made to Be Whole is intended for informational purposes only. It's not intended to replace the advice or care of a licensed healthcare professional. Participating in this podcast does not constitute a provider-patient relationship with Krista Michener, AHP Integrative Health, or any of the guests featured on Made to Be Whole. Krista Michener, AHP Integrative Health, and any featured guests aren't responsible for any losses, damages, or liabilities that may arise from use of information obtained in this podcast or associated materials. Please consult a healthcare professional for any health-related concerns that you are experiencing.
This is Krista. We're going to be talking this week about cancer. I know that there is probably not anyone I know who doesn't know someone who has had cancer, probably someone who's passed away from cancer. Statistically, more than 1 out of 3 individuals will develop cancer in their lifetime. That's a pretty high statistic. About 70% of cancer deaths are from cancers that don't even have recommended screening options. So if you think about available screenings, you think about your mammograms, your pap smears, your PSAs, your colonoscopy, that sort of thing. But 70% of cancers do not have a screening test, and only 5 out of over 100 known cancer types have recommended screening tests. So it's not just the volume of the general cancer diagnoses, but if you look at all of the subtypes of cancer, you have a very, very small fraction, less than 5% that a test even exists for. So there's now on the market a blood test that can detect the DNA of over 50 types of cancer. It's also known as an MCED, or multi-cancer early detection test. Its efficacy is supported by a large prospective study. It started in 2021. It had over 35,000 participants. They first released data from the first participants, and this test was shown to be superior to the United States Preventive Service Task Force screening recommendations. So during the follow-up period, there were 329 cancer cases detected. Of those, 133, because people were assigned to different screening groups, were detected by the blood test, the multi-cancer early detection test. 114 of those were new cancers. 19 of those are people who had cancer, had been in remission, and then it recurred. 20 versus 133, were found through the level A and B screenings of the United States Preventive Services Task Force. So levels of evidence are rated A, B, C, D. Sometimes there's an I for insufficient. So A and B, level A and B recommendations mean that there's actually good data supporting it. So when they were using the best recommendations, those level A and B ones, they found 20 versus 133 from the blood test. And then when they included the class C screenings, so things that didn't have as good of data, that bumped it up. They found 47. So what I think is even cooler about this, of the 114 new cancers detected by the blood test, 53.5% of them were stage 1 or 2, and 69.3% of them were stages 1, 2, and 3. So 70% almost of all the new cancers detected were not stage 4, were not metastatic. There were much better actionable things to do to get better and stay better. Of the cancers that the blood test detected, 75% of those didn't have a common screening option. They would not have been found if we had relied solely on our standard recommendations from the U.S. Preventive Services Task Force. So that's a pretty big deal. And I know someone who's lucky enough actually to work in this field, and she educates healthcare professionals about this test, and it's potentially life-saving. If you look at the clinical trials, they were done across the country at major medical centers, including the Cleveland Clinic. When I first learned about it 4 or 5 years ago, they were already working very hard to get it approved by Medicare. They thought that might happen within a year. It has not happened yet. So I was talking to my friend who educates professionals about this test, and I said, how are oncologists responding? So oncology is the specialty in medicine that focuses on the treatment of cancer. And she was actually quiet for a minute. And then she looked at me and said that one oncologist she approached told her, quote, "It's my job to treat cancer, not prevent it." And that was actually spoken out loud. It's my job to treat cancer, not prevent it. So, in other words, this individual was saying, my occupational and financial security depends on people having cancer and catching it late in the game. Prevention isn't profitable, and our healthcare system is driven by profit. Now, I am not going to take from that and say that all oncologists just care about profit or are interested in you being sick. Obviously, there are good people in every field, but it was actually pretty gutting to me to hear that from someone, knowing that these are the treatment options that our patients have. I've shared previously on the podcast my mom's own story, how she had been treated for breast cancer that was missed by a regular screening, but found by her. Then she had been seeing oncology regularly. She had had some new rib pain, some other symptoms we were concerned about with cellulitis, lymph node stuff that was all on the side the cancer had been on. She had just been to her oncologist, who told her that she was fine, that her pain could not have anything to do to cancer, and to come back in a year. I was still pretty unsettled, so we ran this test and it showed that her cancer was back. It was breast cancer, and she had had a double mastectomy. When we did a PET scan, it had metastasized to her spine. So it was clearly there. It was missed. Now, what was just as discouraging as the fact that she had been getting follow-up and this was missed was that when she tried to reach out for help, instead of being concerned about her or getting her to the next correct step, the tactic was then to question me. Well, who is this that ordered the test? What are her qualifications? Who is her collaborating physician? The concern was not for my mom and her health. It was for attacking the person who ordered the test. I don't really personally care what they think about me, but I'm personally disgusted when you have patients who have information and we do these straw man attacks where we attack individuals instead of evaluating evidence and doing what's best practice. If it's not a test they were familiar with, I would think the appropriate response would be, that's not a test I'm familiar with. Let me take a look at it. Let me take a look at the data. We don't want to have missed anything. Let's get you in here and get things going. Now, interesting, this oncologist saying that he was not interested in this test because it was his job to treat cancer, not prevent it. He wasn't even talking about pure prevention, because if you think of prevention, it's stopping something from happening, right? That's called secondary prevention. You might be surprised and a little disappointed to hear that the amount of time spent by your physician, nurse practitioner, or other provider in their education learning about prevention is really, really scant unless you're being treated by a naturopath or another alternative provider. The education likely just included a few sentences of lip service to smoking cessation and obesity, references to screenings that are made based on industry recommendations, which is not always best science practice, a mockery of supplements and nutrition, and a slew of information on advanced treatment. So what is the type of prevention that that oncologist was referring to, and what is true prevention? So interestingly, almost all of my education on the concept of prevention comes from my first degree, which was not in nursing, not my master's degree in advanced practice nursing. It was a bachelor's degree in community health education that I got from Brigham Young University, where we spent a lot of time talking about prevention, and we spent a lot of time hashing out these 3 levels of prevention. So you have primary, secondary, and tertiary prevention. Primary prevention, if we're talking in terms of cancer, is just preventing people from getting cancer. That would be the very best type of prevention, and I would hope where most of our resources, if not as systems, at least as individuals, could be focused. That would be the best and most cost-effective thing to do. Secondary prevention is what good screening tests to. So you may not have prevented the cancer from happening, but if you have good screening, and you catch things early, you can prevent a lot of complications of late disease. So, a really good screening tool is a type of secondary prevention. What most of our healthcare system focuses on is tertiary prevention, which is preventing complications once disease develops. So, that would be somebody gets cancer, they're getting chemotherapy, we're trying to prevent them from dying from it. We're giving them medication to prevent nausea, which is a side effect of the treatment. We're giving them pain medication to prevent other, life-altering complications, but we're not really preventing disease. We're just trying to kind of put our hand over the gushing wound and slow the bleed is how I would describe it. So again, I'm going to go back to those statistics I cited at the beginning. More than 1 out of 3 individuals will develop cancer in their lifetime. 70% of cancer deaths are from cancers without recommended options, and only 5 out of the over 100 types of known cancer types have recommended screening tests. So we will talk later about primary prevention, but I'm going to talk about screening first. So this cancer test that I'm talking about, it's the GALLERI test, GALLERI. We are, if you catch this episode before April 8th, 2026, Gallery is doing a screening day at AHP Integrative Health, and they will be offering the test for only $699 if you come that day during that time to have it done. You can call our office 330-804-7000 to schedule a time, and we're happy to do this. So that's the test that's available. I think it's great. I'm going to be doing it. My husband's already had it done once. I'm having him do it again. He has 2 grandparents and a father who died in their early 60s of different types of cancer. When I met him, he and his brother had already resigned themselves to the fact that they're going to die when they're 63. And I've tried to encourage him that there might be an alternative to that, because the types of cancer that they had were not inherited. They were more indicative of like environmental exposures and other things that you could prevent and can catch early. And so we're going to just do the screening regularly, because I have a vested interest in him not dying when he's 63, if at all possible. Now, the standard recommendations are for breast, cervical, lung, prostate, and colorectal cancer. So let's go through the current evidence. And I'm not saying that none of these tests should be used. I'm just saying they're not sufficient. And when this is what's held up as best practice, we need to really keep in mind maybe the limitations of what we know now, because we're always learning. We know more now than we did 100 years ago, and hopefully we'll know more in another 100 years. But right now, the United States Preventive Services Task Force, so if you look it up, it's USPSTF is the recommendation, recommends biennial screening mammography for women ages 40 to 74. However, because insurance will pay for it annually, most of the time providers recommend annual, but unless you're high risk, the current recommendation is for every other year. They say that there's insufficient evidence to say whether or not it's beneficial to have a mammogram over the age of 75. So you'll find for a lot of these screening guidelines, they say, hey, if you're a certain age, get the screening. If you're over a certain age, the risk of treatment outweighs the benefit of finding the cancer. I don't think that that's like an outstanding recommendation. There's a lot of difference between someone who's 75 and frail with lots of chronic disease who looks like they might be near death already versus somebody who's 75 and healthy and robust and active and might have another 20 years of life ahead of them. So I think it really has to be an individual decision based on your family history, your current health status, all those sorts of things. Now, again, I am a big fan of this blood test and think that as other screenings get phased out, this becomes even more important. But think of the people you've known with cancer. You probably know someone with breast cancer or lung cancer, but you can probably think of someone who had esophageal cancer, pancreatic cancer, cancers that we can't detect with our current screenings. So there are other things that you can do to screen for breast cancer. So there are ultrasounds, there are MRIs for people who have dense breasts. The United States Preventive Services Task Force says that the current evidence is insufficient to assess the balance of benefits and harms of supplementing screening for breast cancer using ultrasound or MRI. Thermography is also something that some people use. I do not pretend to be an expert on that. I know that people who provide mammograms don't like thermography, but I don't know if that's because they don't think it's a good test or because they make their money doing mammograms. But I personally think that the most important screening is the screening that's done. And so having any screening is beneficial. So cervical cancer, that's what your pap smear is for. Interesting. Again, guidelines on this changed years ago, but you still have a lot of GYN offices recommend that women come every year for a pap smear when that's not the recommendation and hasn't been for a long time because we can stir things up. So the US Preventive Services Task Force recommends cervical cancer screening every 3 years in women ages 21 to 29. Then once you get 30 to 65, they say do it every 3 years with the pap alone, but start adding the HPV testing every 5 years, or you can do a combination of things. They recommend against screening in people under 21, which I would agree with. Most people don't have a risk factor for that. They recommend against screening for cervical cancer in women who have had a hysterectomy with removal of the cervix because, hello, if there was nothing wrong with your cervix when it was taken out, the risk of cervical cancer is pretty low. They might still do screening if there's a cervix. And then they say, hey, if you're over 65 and you've had adequate prior screening, we recommend against screening. So that's their story. They're sticking to it. Again, you have to look with all of these cancers, I think, at is there specific risk for a specific cancer based on family history or labs? Because there are labs that can tell us about risk for certain cancers and show us who should be doing maybe a pap more frequently or a colonoscopy more frequently. But everybody's very, very different. And I think what I have seen a trend that I think is concerning and maybe a little self-sabotaging is that because people are seeing, there's some flaws in these recommendations, and maybe I have some safety concerns about mammograms or this test or this screening is just a moneymaker. And so what they do is they cast aside all screening because they don't like currently available options. But screening's a really, really big deal because if you wait until you have symptoms of cancer, it's not good. For the most part, if you have symptoms, it's much, much more advanced. And you read about people like my great grandmother who died in her 30s of breast cancer. And when you read about people in history, cancer's been all around a long time. Now, is there more of it now? Yes. And there are a lot of concerns with that. But cancer's been around a long time. And it used to be, it was pretty much a death sentence because nobody found it until there was a visible lump or they couldn't get around, they had advanced symptoms. So just because you may have concerns about certain screening options doesn't mean the concept of screening is bad. And that's what I'd like you to take away. Now, lung cancer is an interesting one. They don't recommend it for everyone, but people who have a history of smoking, and the official guidelines is that if you're between 50 and 80 and you have a 20 pack year smoking history, so basically if you've smoked the equivalent of a pack a day over 20 years, then you should be doing this. Or you've quit within the past 15 years. So even if you quit, but it's been less than 15 years, they recommend doing it. And it's a low dose CAT scan of the lungs is what they recommend. And most of the time, if you have traditional insurance and you have the smoking history, they will do the low dose chest CT. One thing that I have seen, just side note here, that I find really, really sad, one of the things that discourages some people from lung cancer screenings who have a smoking history is how they are treated. I have one friend who was diagnosed with lung cancer and was treated exceptionally poorly in the ER when it was found because of her smoking history. Make a lot of judgments about people and their character, and that's disgusting. Don't be that way. Everybody has risks. We've all done things that aren't the best for our health, and it's our job to meet people where they are and help them. That aside, one of the more controversial ones, and the age at which we start screening for this has been a shifting value, is the PSA, the prostate specific antigen test for men ages 55 to 59. They used to recommend starting to check it over 40, and then it was 50, now it's 55. And they say, well, that, whether or not you do this is an individual decision. Men should have the opportunity to discuss potential benefits and harms of screening with their clinician and to incorporate their values and preferences in the decision. What I don't know why I'm laughing at that is there's this line of whatever fantasy land about individual decision, look at their preferences and values. But once you reach treatment, nobody cares about that at all. It's like, here's our standard line, and what you want doesn't matter. It's our way or the highway, with a lot of providers, but whatever. That's the official line now. So screening offers a small potential benefit of reducing the chance of death from prostate cancer in some men. However, many men will experience potential harms of screening, including false positive results that require additional testing and possible prostate biopsy, overdiagnosis and overtreatment, and treatment complications such as incontinence and erectile dysfunction. Determining whether or not this service is appropriate in individual cases, patients and clinicians could consider the balance and benefits and harms of the basis of family history, race, ethnicity, comorbid conditions, blah, blah, blah. Clinicians should not screen men who do not express a preference for screening. I don't know. I just think that's a big line of bull, because to me, the problem isn't with the fact that a PSA is being done, the benefits and harms of screening. It's a screening for an inflammatory marker. What should be improved is the cognitive abilities of the morons ordering and interpreting the tests. So yes, it's possible that somebody can have a PSA that's slightly elevated because it's an inflammatory marker. So what do? You don't send them right for biopsy and prostatectomy. You say, okay, what could be causing this elevation? Well, let's recheck it in a little bit of time and see if it comes down on its own, if it's a slight elevation. Let's see if there could be an infection of the prostate, because that's a very, very common thing, especially as men get older. Let's find better screening options before we go chop people up. So I have a few emotions on that, but again, I just think it's silly. You have this test that can provide some value if people know how to interpret and use it. And don't blame the test on the inadequacies of the people interpreting it. And if treatment, as they are admitting here, can cause so much harm, why aren't we rethinking treatment? Because we've got some real shortfalls in what we are offering to people as standard and necessary. But side rant. So finally, colorectal cancer. If you watch TV, you've heard about this, that colorectal cancer rates are on the rise. The current United States Preventive Services Task Force recommendation for screening for colorectal cancer is for all adults ages 50 to 75, but a lot of insurances now are paying for screening at 40 or 45. So it can be done earlier. Your standard screening options are colonoscopy and Cologuard. Now, when Cologuard first came out, GI guys were throwing a fit because it was a terrible inferior test. And I still remember the Cologuard people coming around and saying, hey, the best test is the one that's done. And if you have people who were not willing to get a colonoscopy before, and they're willing to do a poop test that can detect the DNA of colon cancer, isn't this good? And can there be false positives? Yes, but the reason is you don't just operate and start chemo. If they get a positive Cologuard, then you would do a colonoscopy, but you have a compelling reason to do one. Are there people who should get colonoscopies? Likely based on family history. If you've got a family history of early onset colon cancer, if you've had a lot of polyps or other risk factors, we don't want to throw the baby out with bathwater, but just recognize that we are not hurting people by recommending alternative screening, because there are risks with screening. So, for example, with a colonoscopy, you have anesthesia risk. Now, for a lot of people, that's not a big deal, but I have some patients who that's a very, very big deal. So we just have to look at the whole picture. Again, USPSTF recommends that they selectively offer it to patients ages 76 to 65, decide whether it's appropriate, yada, yada, yada. So the way the Gallery test works, it screens for this cancer signal that over 50% of cancers have. It's intended to detect cancer signals and predict where in the body the cancer signal is located. So, for example, with my mom's test, and this is with her permission, we had done Gallery a year after her initial breast cancer treatment. It came back negative, no cancer signal detected. So that gave us some confidence. A few years later, when she was having symptoms, we redid it and it came back. It said cancer signal detected, predicted site of origin, breast. And that was absolutely right. It was the breast cancer. It had metastasized to the bones, but it correctly identified that. People who should not do this screening, they will not do it if you're under 21. They're working on getting some approvals for younger patients. You shouldn't be doing it if you're getting treatment for cancer or if you are pregnant. So if you look at this from a statistical standpoint, the performance metrics, it has a really, really high specificity. So specificity is 99.6%. So what specificity is, it means there are not going to be false positives. If a test is highly specific, you are not going to get tests that come back and say cancer signal detected, but oh, it turns out it's not. And a lot of people are getting scared. And the accuracy of its first CSO, the cancer site of origin, is 91.7%. So that's really good. That means it comes back, it says there's a cancer signal detected, and 92% of the time it's going to be accurate about, yes, this was a breast cancer origin or testicular or liver cancer origin. Is it perfect? No, but I'm telling you, that's a really good tool. Sensitivity is a little lower because we don't want a lot of false positives. So sensitivity means that you are not, that you're picking up all of those cases. So you have to balance sensitivity and specificity. You don't want false positives, but then with the false negatives, it means that 73.7% of the time when there was cancer there, in this group of 12 cancers they were looking at, they said, hey, in these common cancers, that 73% of the time they caught it. Now, does that mean that over 25% of the time it didn't? That's true. But remember, most cancers, 70% of cancers, there is no screening. So catching even 73% of those or 50 or 40% of those is really, really good. The sensitivity varies by cancer. Some are easier to pick up than others. What this test is not good at picking up is anything in the brain, because the blood-brain barrier protects that, and you may not have that circulating DNA of the cancer. So a lot of statistical mumbo jumbo, but just to say this is a robust test. What do you do if there's a positive? Well, Gallery gives us really good support and help in getting to patients right away and getting you referred to the right person for the next step. AHP is not your treatment destination. Most of the providers at this point who are willing to use this test are not going to be the ones providing treatment, but they can help fast track you to get you to the right place right away. And I'm telling you, the fact that there is a possibility of detecting esophageal, pancreatic, gallbladder cancer, stage 1 or 2, is an absolute miracle, because they're very, very treatable in the early stages, and the prognosis is not good in the later stages. Plus, the treatment becomes much, much more intense, and it has a worse impact on quality of life. And you have a lot of difficult decisions to make about which treatment to engage in and which not to. And we're going to talk more about that in next week's episode. We're going to look more at primary prevention and also what we can do to support the body during treatment, because there's a lot of overlap in those two categories. So if you are interested in getting this screening done, we do offer it year-round at AHP Integrative Health, but we will be having that special rate offered by the company of only $699 if you come to our office between 3 and 7 on April 8th. Give us a call at 330-804-7000 to schedule, and remember to have hope, because you were made to be whole.
Have a podcast question or suggestion? Text or call us on the podcast info line at 330-439-0686. Thank you for spending time with me today. If you like what you hear, please subscribe to be notified when new episodes release. And remember, you were made to be whole.